Good morning, everyone. Slide number 5. History given was newborn failure of the bowel movement. This is the HNE 40X showing rectal biopsy shows the absence of the ganglionic cell with the large submucosal nerve with the perineurium, which is the hyperplasia of the nerve. Diagnosis: Hirschprung disease. Review of literature. Introduction. Hirschprung disease is the most common cause of the lower intestinal obstruction in the neonates. Hirschsprung's disease is the congenital anomaly, aganglionic megacolon, by the migratory failure of the neural crest cells, leading to abnormal innervation of the bowel. The fundamental pathology in the Hirschsprung disease is the absence of ganglion cell in the submucosal and intermuscular nerve plexus and associated with the increase in the nerve fiber in the affected segment. That aganglionic segment usually involves terminal intestine. The rectum or rectosigmoid is the most common site. The aganglionic segment may, however, include the entire large bowel and sometimes even the small bowels. Incidence: 1 in the 5,000 live birth. 80% is sporadic. 18% is associated with the other congenital anomalies like the Down syndrome and some with the specific syndrome. 12% have the major chromosomal abnormality and 10% associated with the Down syndrome. Clinical feature: failure to pass the meconium in the first 24 hours of life. In neonatal intestinal obstruction, symptoms include the biliary vomiting, abdominal distension, and refusal to feed. Recurrent enterocolitis mainly present in the first 3 months of life. In toxic megacolon, fever, abdominal distension, bile stain vomitus, and explosive diarrhea with dehydration and shock. Spontaneous perforation of intestine occur in the 3% cases if there are the long segment aganglionosis. Chronic constipation patient may have the chronic constipation in response to change in the feeding and may have the growth retardation and fecal masses or in the abdominal examination. Grossly, if we can see, there are the distal end, which is the aganglionic, which is the at the site of the both side of the proximal and distal end. The biopsy we will take. Distal end is narrow and proximal end of the intestinal is proximal intestine is a dilated part. If we see microscopically, which does not have the Hirschsprung disease like or in the proximal part of the intestine, there are the presence of the ganglionic cell, which is the by the black arrow, and submucosal nerve plexus, which is indicated by the white arrow. In the Hirschsprung disease, if we see there are the transitional zone Hirschsprung disease, which is the lengthy circumferential and stretch of the predominantly tiny ganglia, which is shown by that arrow, and which have the minimal neuropil, which is seen around the 1 or 2 ganglionic cells. Aganglionic segment, which is the complete absence of the submucosal and mesenteric ganglionic cells. Immunohistochemistry: if we do the immunohistochemistry for the acetylcholinesterase or the choline transporter, both demonstrate the increase the cholinergic innervation in the lamina propria and muscularis propria, which is absent in the normal intestinal study. This is the photograph which is showing the acetylcholinesterase, which is transporter positive neurites are present in the muscularis mucosa and the lamina propria, and the neurites are very slender. Differential diagnosis of Hirschsprung disease: chronic idiopathic pseudo obstruction, which is clinical condition with heterogeneous etiologies and most affect the small and large intestine with some primary like visceral myopathy, mesenteric hypoganglionosis, and some secondary from the hypothyroidism. Second is the megacystic microcolon intestinal hyperperistalsis syndrome, in which bladder and intestinal dysmotility seen, typically present pre or perinatally. Mutation in the gene for the smooth muscle contractile protein. X-linked intestinal pseudo-obstruction and meconium ileus. If we see histologically, there are the neuroglial hematoma syndrome, in that main type 2B neurofibromatosis and P10 hematoma syndrome, in which ganglioneuromatous hyperplasia seen of the submucosal and mesenteric plexus with absent or present of the mucosal ganglioneuroma. Primary visceral myopathy, which changes the rarely diagnostic in the muscularis propria of the rectal biopsy. Key features include the muscle atrophy and fibrosis as well as the myocyte vacuolar degeneration. Thank you.